Time is very late. We are now all colleagues are hungry. I will talk about a few sentences about the hysteroembryoscopy of the recurrent pregnancy loss. As we know, the pregnancy loss in the first trimester occurs in the first 12 to 14 weeks of the gestational age. Most of them cause the genetic variations. Most of them cause genetic abnormalities. The early pregnancy is non-viable intrauterine pregnancy with either empty gestational sac or gestational sac containing an embryo fetus without fetal cardiac activity, as you know. Approximately 80% of all pregnancy losses in the first trimester. The early pregnancy loss occurs in 10% of all clinical diagnosed pregnancies. Almost half of the early pregnancy losses are due to fetal chromosome 1 abnormalities, as you know. When we check the incidence and ratios of the recurrent pregnancy loss, 50% of the RPL cases do not have a clearly defined etiology. The common etiology is the most of the genetic factors, anatomic factors, endocrine and antiphospholipid APSL, and autoimmune and thyroid functions and thyroid dysfunction and infections. Spontaneous abortion management, expectant medical or surgical management. Expectant management, I'm passing. In the medical management, some drugs can give for the relief and the opening of the cervical canal and contraction of the uterus. Surgical management includes first vacuum aspiration, dilation, curettage, dilation and evacuation. And hysteroembryoscopy is not a new technique, maybe almost the last decades some researchers can do it. This is the hysteroscopic method of the embryoscopy. This is our case. She is 28-year-old, gravida 4, parity 1, abortus 2. History of 2 missed abortion in 8 and 12 weeks of the gestation. She has no additional disease. The transvaginal sonography revealed 10 mm no fatal heart rate in 7 weeks of the embryo. The considering the patient's previous obstetric history, hysteroembryoscopy and hysteroscopic evacuation was planned and appropriate management option, and patient gave consent after the informed counseling. The perioperative image of the missed abortion, this is our images, and I'm going to show the live video. As you know, the gynecologists are very familiar with the hysteroscopy. The entire uterine cavity, we do the office hysteroscope now using saline infusion, and we see the gestational sac. We are now in the chorioembryonic cavity. We are observing the endometrial cavity where the gestational sac is located, or any another additional abnormalities in the cavity. You see the fundus and the tubal internal osteums. Now we are opening a little bit bite and entering the gestational cavity. Now we are in the gestational cavity. We are gently moving, very, very gently, because not to disturb the embryo, not to disturb the gestational sac. Sometimes it could be challenging. You see the embryo. This is 7 weeks old. This is the upper limbs. And you see the hands, ears, nose, and the face of the embryo. And the upper limb. And you see the golden ring. We see this part as a yolk sac in the sonography, double ring, and also called golden ring, and umbilical cord attached to the yolk sac to the embryo's body. And then it dissolves, and
Good morning.
the
The
placenta
state is to provide final
produce
limitation and that
oxygen and nutrients to the fetus. This procedure allows us to both microscopic or magnified view to introduce, to identify its macroscopic anatomy. If it's a macroscopic gross anatomy, we can conclude and discuss with the patient for the next pregnancy for genetic counseling. And also after this operation, also sure we evacuate the uterine cavity. But when we evacuate uterine cavity by dilation curettage or blind curettage, the maternal decidua comes to the injections and we send to the genetic. The genetics sometimes can be challenging, cannot be diagnosed. So we eliminate the maternal contamination and we can take biopsy by forceps, microforceps or microforceps from the fetus to investigate the chromosomal whole genome for the fetus. There are some drawbacks of the blind curettage, such as cervical trauma, uterine rupture, bleeding and infections. And I told also why we choose this method. Thank you very much for your attention. Time is very late.